one of the biggest struggles. One of the biggest, struggles or negatives, because I really love the job that I do, but the one negative that I could really, highlight if I had to, is the failures, the surgical failures, so it forced me to think about this a lot more than I normally do, even though I think we all think about it all the time with our patients. But so I'm excited to speak, and I'll move along. I don't really have any disclosures other than being in the SLATE trial, which is a multi-center surgical trial for laser ablation. I thought I'd just cover real quickly these objectives. But it's what defines a surgical failure is not a given. And then we do know of some reasons why people have surgical failures, and it's good to sort of abstract and classify those. And then we have all of these identified features of epilepsy, whether they're clinical or EEG or imaging, that can be associated with failure. But how to weigh those and use them is important to talk about. And finally, I think there's so many unknowns, it might be worth talking about, setting up a foundation for discussing what we need to learn. So this is just an overview, and I wanted to just briefly talk about what defines surgical failure. I was initially focused the entire talk, and ultimately do focus on seizure freedom. But talking to my colleagues just even yesterday reminded me that, you can have patients that are seizure-free, completely seizure-free, but have permanent deficits, either mood deterioration or neurological deficits that don't resolve. A lot of them typically do if you can get through the first 6 months or a year. But some don't and regret having the surgery, even though they're completely seizure-free. Others see it as a failure if they're not cured off medicine seizure-free, which is something we don't anticipate that often, but it does certainly occur. But it's often what patients wish. They really hate the medicines, and it's hard to sort of prepare them for that expectation that probably is not possible. Anyway, I will move past this and go to the reality. If you take all comers, and I think this would be the case for all of us in practice, no matter where we practice, that half of our patients do not become seizure-free. And it used to, that's the reality. Yeah, I mean, you can super select and get better, but if you just take all comers and doing a good job, half your patients are not going to be seizure-free. And that sounds appalling, but that's a number to treat of 2, which is far better than most interventions, surgical interventions you can think of, like carotid endarterectomy, coronary artery bypass graft surgery. Even for mortality, just the effect on mortality, it's actually quite effective. But that range is really from 30 to 80%. It's not 50%. And that range also indicates the variance and also the things we need to learn and understand. I thought also I would talk about, before really diving in, about outcome measures. I already kind of alluded to, being completely seizure-free. And there's an analogous in the ILAE system of breakdown. You sort of really could pair these up pretty good. But I just wanted to focus on seizure freedom. And the Engel outcome scale has 4 subdivisions, and you probably all know 1A is complete seizure freedom, and 1B is non-disabling seizures, mainly auras only. And 1A and 1B are considered, almost equivocal in a lot of ways, but because you can drive, you can work for the most part. And however, auras, as I mentioned, they can alone be considered a failure for patients. They really don't like them. But I'm fascinated by 1C and 1D. 1D is when you try to wean somebody off medicine, or if they do it themselves, which they frequently do, and they have a seizure, convulsion typically, and then they go back on medicine and they're seizure free. So that one's kind of interesting. But even more interesting is 1C. And I discovered this more recently. I don't think I really appreciated it. And that 1C is having had some disabling seizures, but 2 years or more, the last 2 years or more, you're completely seizure free. And I was just looking at outcomes on a large number of temporal lobe cases, the cases that do well, I mean, all the unilateral cases with hippocampal atrophy, that's ipsilateral. And I discovered, I thought, oh yeah, we have like about 60% twos and ones and 40% ones, or I'm sorry, 60% ones, and everybody else maybe 40%. But when I started looking at it, it was more like 50-50. But then as you looked at over time, a lot of the twos converted to 1C. And that was just totally fascinated me why that happened. A lot of it actually is patients in the first year and second year, there's a lot of variation in compliance or even attempts to maybe lower medicines by physicians. And eventually after that dust settles and you go back to whatever medicines you were taking before, you return to being seizure free. But nonetheless, I think, I mean, these are important, 1C, B, and C and D, because a lot of the outcome studies are based on Kaplan-Meier survival curves, and 1C, those folks they're off, they didn't survive. Same thing for 1D, they didn't survive either. And yet these patients are seizure free, ultimately seizure free, and all the benefits that come with that, including the effective elimination of SUDEP, are present in those patients, and yet these survival curves miss all of that. So I really have a little struggle with that, but I just bring that up as a little editorial. There's also, when you look at outcomes, you have to sort of overlay this little matrix, I think, and to help clear up some of the confusion. And it's basically larger resections, big lobar resections, multi-lobar resections are going to, no matter what, have different outcomes. And, and just the basic anterior temporal lobectomy, the standard resection is a bigger resection. And that shouldn't necessarily be compared with more tailored resections, and certainly not lesionectomies. And whether this epilepsy is in the medial temporal structures or anywhere else, neocortical epilepsy, that too likely has a big interaction on outcomes. I think most of us know that, but it's good to remember that I had a hard time getting through some of the confusion of every type of outcome study that's done. And really, you do have to lay that matrix on every study. So now I just wanted to filter down some of the confusion, say, of all the failures, maybe we could classify, there are definitely times when you identify you just couldn't remove enough of the tissue, couldn't even remove all of the seizure onset zone, or you went in knowing it was going to be a palliative resection. Or what can happen, even in the best centers, we identify the wrong location, or at least partially the wrong location of where seizures come from. There still is somewhat of a needle in the haystack when imaging is negative, and scalp EEG can even be completely negative. And we're based on going on semiology, or we'll talk a little bit more about this, or we misinterpret tests and weigh them inappropriately. And then the other is, and this is a common one, you may believe there's only one location, but there may be more than one location, and that you may have very good reasons for believing there's one location, but it still can be bilateral temporal lobe independent epilepsy can exist even when there's no great indicators of that. And there can be second sites that rise up inexplicably. I hate to say it. So insufficient resection or ablation, so focusing basically on removal of tissue. The most common, is it the most common reason for failure? My sort of 25 to 30-year history of sort of experience was, my answer to that question would be yes, but I really don't know that. And looking at the literature, I can't say that for sure, but there's a good amount of reoperation literature that would say that it's certainly common. Another thing that's sort of surprising, even with these lobar resections, or what are sublobar resections, like an anterior temporal lobectomy, even in patients with unilateral hippocampal sclerosis, unilateral ictal and interictal EEG, and everything perfect, some still fail and respond to reoperation. One of the questions I always ask myself, because I'm always thinking the patient's going to ask me when we do a reoperation and it's successful, why didn't you do a larger resection in the first place? We can talk a little bit about that, maybe in question or discussion. But just to talk about reoperations, this was just one study I picked out of many because it was a large meta-analysis and sort of covered a lot of territory and a lot of patients. And I think none of this is surprising. These are the odds ratios of positive predictors of a reoperation being successful. And congruent electrophysiology, and this is congruent electrophysiology prior to the first surgery, and lesional versus non-lesional, and a surgery that was limited for reasons unrelated to being disease related. So all of those make sort of obvious sense, but they still raise the question of why we didn't do a larger resection in the first place. The other is, these are just some individual papers that I selected I thought made a good point. This older paper goes all the way back to Alan Weiler in 1989. He's sort of I don't know if any of you know him, but he was very well known in the 80s and 90s for doing a randomized controlled trial of resecting only part of the hippocampus versus all of the hippocampus. Basically based on, we didn't know if it mattered, and there was potential upside for preserving some of the hippocampus. But so that was before this 89 paper, when he concluded that yes, enlargement of original resections is definitely valuable. And this was mostly medial temporal lobe epilepsy. This was this paper by Dr. Jehi at the Cleveland Clinic. Kind of surprised me that early recurrence of seizures and more frequent seizures do better in reoperations. And this was both for medial temporal and extratemporal. And this larger paper, this is a pretty amazing paper actually, also from the Cleveland Clinic, of 898 resections, 110 had reoperations. Of the ones that didn't have reoperations, 68% were seizure free. So I don't show them the slide, but they just made a point of there's significant seizure freedom that can occur after a reoperation, 42%. Most studies, it's around 50%, by the way, but it's close enough. But even another surgery, it's lower, but you still can have success. They were making the point that at some point you can define surgically intractable cases or just uncurable cases. Actually, this is an important point to make, that we make the assumption that if we're taking the patient to surgery to do a focal resection to eliminate seizures, that the patient is arguably curable, that meaning that they do have unifocal epilepsy, and that if we've done everything right, that the prevalence for the possibility of seizure freedom should be 100%. And that allows us to do positive predictive values, to use positive predictive values pretty simply. But there is, no matter what, a percent of the population of patients that we choose that even if we do everything right, no matter what, are probably not curable. So an incorrect location, this I think we all have experienced this, thankfully not too often, but one of the biggest reasons is, in my experience, in being from a diagnostic imaging person, is error in interpretation of scans and weighting those scans. It's remarkable, what little it takes for a radiologist, a neuroradiologist, to say in their wanderings about what might be related to a patient's epilepsy, even though they don't take care of patients with epilepsy. And yet we target these areas, and it leads to potentially the wrong target altogether, or sampling error in general, which is already a large problem when we are trying to judiciously place electrodes in or on the brain. And even in the best circumstances, we have sampling error. Oops, sorry. So now we're going to focus what really interests me the most. All of these things interest me because they're all real world problems. But what about the unifocal epilepsies, true unifocal epilepsies? And you have the correct localization, at least by all definitions of correct localization. So they're unifocal, they have one type of seizure, the exact same aura every single time. You have EEG, neurophysiology, and imaging that really are conclusively positive. When I call that's a diagnostic term, but they are conclusively focal if it's electrophysiology, or conclusively positive if it's imaging, meaning that there's a single spot that is unequivocally abnormal and unequivocally epileptogenic. And patients still fail. So, so I was going to pick on this. I think we all know this, but I still abide by this axiom that, if we can figure out where the seizures come from and remove that tissue where the seizures start, the seizure onset zone, we should theoretically make the patient seizure free. That's been, that is just sort of the main theme of everything we teach. There is a reason we contrast this definition or this term with the epileptogenic zone, which is an unknown. It's a great term. It's the region of brain, and only that extent of the region of the brain that's necessary to remove to render the patient seizure free. But those don't actually always mean the same thing. But conceptually, they should. So this is a patient that just one of the very, very many that has perplexed me. This is one of these very, very focal onset seizure patients, very stereotyped. He is MRI negative, so he's idiopathic. It's in a tough area. It's left dominant hemisphere, posterior left dominant hemisphere. But it's more complex visual hallucinations, and they're very specific every single time, as I've described here. Usually, but not all, and certainly not always, does he can convulse. That's negative, but it's not that common. Usually just has a really bad migraine headache afterwards. He's totally normal, master's degree level of education. He has really normal neuropsych testing. This is his scalp EEG. And this is just standard 10-20 scalp EEG with a couple of, just standard 10-20 and with FT9 and FT10 and A1 and A2 placed. And this just shows a really nice scalp focal ictal pattern over the posterior, left posterior quadrant. This is scalp EEG source localization. Even with low density EEG, it can be accurate. And indeed, looking at the center of this sort of estimate of source generator for the seizures, this is the PET scan, nice, very focal PET, unequivocal. That green dot represents the center of the source estimate, source localization estimate for scalp EEG. And if I don't screw this up, we'll be able to see his seizures. So we have a lot of electrodes placed over the posterior quadrant, both laterally and inferiorly and some medially. No depth electrodes in this case. I can see, let's see if I can get this to start. So I'm going to drag this to the seizure onset. And it's these bigger spikes, but we're going to get there. So this is the seizure onset. This is how focal the seizure onset, even though you can see he has these spikes that involve a lot more tissue, but it is all of his seizures start exactly like this. And he has a very long lead in. It's very focal, it just goes on. That's why I thought, man, if this guy's not seizure free, I give up. And I'm just dragging over seconds and seconds and seconds. And this is just based on line length because it takes advantage of both frequency and amplitude. And this is just like, okay. And it goes and it finally spreads out of this region more laterally and more anterior laterally into areas you don't want to go, most likely because of language. Yeah, this is how I'm going to run out of desktop, spread my mouse just to get to the end of the seizure. But well, one thing I noticed too, that it actually left the region that it started in. And it doesn't always happen, but so that might have been something to look at as a negative. Anyway, these we're going to skip because they were, just in case the video didn't work. This was his mapping, stimulation, reproduced his auras in the same location as we found the seizure onset, or maybe a little bit more rostral. Also, whatever kind of deficit he might have. This is very lateral. It's certainly not going to cause a visual field cut or anything, but it is potentially going to cause scotoma or some other visual disturbance. But he went ahead and elected to have surgery. We did a larger, a fairly, we thought, generous resection that certainly included all of the seizure onset zone. And he had pathology that's typically associated with a pretty good outcome. It's not as good as 2B. We knew this probably wasn't going to be 2B in the first place, but 2A is usually somewhat of a positive. But he is not seizure-free at all. He really didn't change anything. All he did was get a scotoma that makes it more difficult for him to read. And yet this patient, which was like the next week, not a whole lot different, except just a little bit more anterior. This seizure, this is the seizure starting, hasn't quite started. There we go. This is this onset. Nice basal, not medial temporal. It takes a while to get to gradually really progress. This is many seconds to involve medial temporal structures, but it does. She's completely seizure-free. She had the exact same pathology, focal cortical dysplasia 2A. They're not exactly well matched, though. This patient, we did include the hippocampus in the resection, so we didn't just stay with the seizure onset zone. So maybe that tells us something. But my point was really that they're very similar pathology. They're very similar focal onset seizures, and one is completely seizure-free and the other is not. I didn't even remember that we had taken the mesial temporal structures, and probably maybe that made a difference. I don't know. I'm not sure it did. I think she just was going to be seizure-free. But whatever the reason is that makes her capable of being seizure-free with a very similar resection versus the prior patient is what we need to learn. Skip these again. There's also lesion variance, I think everyone knows, but I think it helps again to sort of simplify the very complicated field, that there are some lesions that when you do a lesionectomy, they have a high likelihood of being seizure-free. And I put those in the left. PXA is a pilocytic astrocytoma, usually in children, but can be in adults. But you can go through the literature and see great seizure-free outcomes for these. Not everybody, but they are definitely, you could separate them from the rest. Gangliogliomas, cavernomas, and oligodendrogliomas certainly do well, but they are much more common to have recurrences. And that in oligos and ganglios, it doesn't necessarily mean the tumors recurred. It's frequently because of dual pathology. And cavernomas, I think that's an interesting difference. So excluding the possibility of another cavernoma causing seizures, let's just say it's a single cavernoma, and you've resected everything. Let's talk about that. So this was a patient I just recently had too, who's just makes me want to quit my job, basically, because I thought, you can't do better. He had very stereotyped seizures. I just wanted to show you his imaging here. And this is his history. He's 35 years old. It's totally normal. Works in, in tech and married. Started having seizures at 33. In retrospect, probably had focal seizures. He had these quote unquote panic attacks that certainly in retrospect sound like they were part of his typical aura, which has this sudden chill, these shakes, these shivers, sort of stares. He can communicate with gestures. I've watched a lot of videos of him on the trail. He frequently has these when he's trail running, and his wife usually runs with him, but she's slower. So she usually ends up running into him because he's walking along the trail in the middle of a seizure. So when she approaches him, and he can totally kind of communicate with her with gestures and even speak a little bit, but and every time they look exactly the same. And when he was evaluated for surgery, same type of seizure. The scalp EEG, I will say interictally had rare sharp waves, but they were in the right location, the inferior frontal, anterior temporal, perfect location. And his seizures were not, the scalp EEG was just marred by muscle artifact, but it was certainly right frontotemporal. But anyway, back to his scan. So he had this single cavernoma in the posterior gyrus rectus, or mid aspect of posterior gyrus rectus. And he had a complete resection. When we did what we thought was everything correctly. We did electrocorticography. He definitely had very frequent spikes. We resected the lesion plus the spikes and the surrounding hemosiderin. Those are all the three things that maybe could affect outcome. All of it done, completely resected, no hemosiderin remaining. Still has seizures as frequently as he did before. He did have 2.5 months of no seizures. He usually has at least 1 or 2 a week, so that was something. But so why did he fail when the following week we had another cavernoma? It was totally seizure-free, similar. This was kind of interesting. I thought there is a lot of literature on cavernomas, but this paper by Dr. Jahi made a point of longer duration, which is a common theme, is an increased likelihood of failure. And that if there's any way that the cavernoma, if it's extratemporal, could be connected to the limbic network, then there's a higher risk of failure, largely because you're probably going to have to involve the limbic network or involve the temporal lobe. And that's an easy case when you have a cavernoma that's in the temporal pole. Frequently, those patients do get a temporal lobectomy that includes the mesial temporal structures. Not always. And indeed, though, if you do a temporal lobectomy that includes a lesion plus the medial temporal structures, lo and behold, they do better. So there's thousands of papers on predicting outcomes in surgery, epilepsy surgery. And just sort of culling through a number of these, some of the better ones. And I think these are all sort of ingrained in our experience as well as our own knowledge of the literature. But I just pulled out some of the ones that really stand out in most studies. But you remember that we sort of have to overlay the neocortical epilepsy versus temporal lobe epilepsy, medial temporal lobe epilepsy on the weighting of these somewhat. And of course, depending on the type of surgery the patient had, these weights may or may not apply. But normal MRI is one of the biggest, it's one of my biggest interests in epilepsy surgery, even though more people do fail with normal MRI. But I've always preached that that doesn't mean they can't be seizure-free, and that is true. But it does make it more challenging and less likely for the patient to be seizure-free. One that probably comes up the most is long epilepsy duration. That is true to a large degree, but in my recent several years, I've had 3 patients in their late 60s have temporal lobectomies, and all 3 of them are as seizure-free as every 20-year-old I've done surgery on. So it's certainly not a lock. And these things have to be weighted. It's tough. History of convulsions comes up a lot. Frequency of seizures, different ictal scalp EEG patterns if they're not focal versus regional. I've just showed you patients with incredibly focal ictal patterns that still fail. incomplete resection, I think that's self-explanatory. One that kind of surprised me a little bit, but it makes sense intuitively, is a non-focal neuropsychological deficit. I don't think it's a strong weight. If it were, we wouldn't do a lot of surgeries. And then if you have pathology after the surgery, non-specific or normal pathology is definitely a negative predictor. But really, when I'm going to, how do we use these? We certainly do epilepsy surgery, successful epilepsy surgeries in patients that have any of the, any combination of these, maybe even all of them. Probably not incomplete seizure onset resection, but in sometimes. So there's been some pretty cool papers of recent, really good work. A lot of it coming from Laura Jahe at the Cleveland Clinic and others working with her, that I was initially sort of not that enthusiastic about, trying to predict patient seizure-free outcomes. One, I know it's still relatively modest, but the other was I didn't want to scare patients away from surgery because I'll talk about it at the end, the reverse risk of precluding somebody who could be seizure-free from having that opportunity is a big deal. This is actually one of the fellows, Laura's, that published a couple papers on this really simple scoring system. I thought it was pretty remarkable because they had large numbers of patients. You can see the numbers. There's like over 300 patients in many years, this cohort. And it was really simple. Like, we'll pick out, and they did logistic regression and really did careful analysis to figure out which variables that you could give the most weight to. And it's pretty cool. So normal MRI, bummer, it's my favorite patient population. Frequent seizures, that's a lot of seizures, very, very frequent. And epilepsy duration and history of GTCs. So those four, that's their sort of simple scoring system, has a really good predictive, or at least, it's a graded prediction you can see on these survival curves. These are Engel 1 survival. I don't know how you do a survival curve with Engel 1 outcome unless it's Engel 1A only. And I don't think that's what this was, yeah, I mean, every additional point you get, you drop off. It's almost linear in your likelihood of long-term seizure-free outcome. And then they made a modified scale that was kind of cool. They added two things, just the fact that you had to use invasive EEG, which we all know that just subselects for patients that are more complicated, more difficult. And if it's not medial temporal lobe or extratemporal lobe. And then you do something even more simpler. If you use that modified scale, you could just say, do they have none of those negative predictors, or just a few of them, or all, or near, or most of them? And you get this bottom survival curve, which is pretty amazing. Like, I think most important probably is, well, I guess you could argue either way, but I was gonna say the most important is the 184 patients that had remarkably good outcomes, even to 10 years, but we'll talk about the problem of if you did that, if you said, yeah, I'm going to use this score and I am going to only do surgeries on those patients with 4 to 6, with a score of 4 to 6. And I apologize, I kind of made that. You get points for not having these negative predictive values. So the more points, the better. But yeah, you could say, we're going to just super select and only do surgeries on patients that have a score of 4 to 6. Again, that brings up this problem of the reverse risk that I think is not trivial. But Laura's, and this is her really good work with nomograms, which is sort of a kind of a different way of doing this, maybe a little bit more nuanced, but not necessarily any more reliable in predicting. But her argument, and it's a good argument, would be that it still helps to provide some information to patients so that it creates expectations, because I think we all experience it, no matter what we tell patients, or at least many patients, and it's hard for them to think other than this is going to fix me or not fix me. Having some kind of numbers like this, like, okay, and this is an example, this is just how to use these nomograms. And this one's more nuanced because you can have patients with either frontal lobe or posterior quadrant or temporal lobe epilepsy. And you have a little bit of differences in weighting based on that, not much, basically based on the duration of epilepsy. But it's important to, again, she's overlaying, she's showing that overlay makes a difference of where the seizures come from. And this one's a little bit more of a simplified version. There's even more nuanced versions, but takes into account those things that they found to be best weighted in a large population that it was tested in, a cohort, and then validated in another even larger multi-center international collection of patients. And ultimately, this little nomogram basically converts these distributions and percentages into numbers, like a total point score that gives you some estimate, a reasonable estimate maybe, of your likelihood of being seizure-free at 2 and 5 years. And I kind of have totally come around to, yes, it is kind of helpful to do this. I don't want to scare patients away, but it is definitely good to help create more real-life expectations of outcome. I bring up, this is a paper that that was recently published, and there's going to be a slew of these coming, because as you know, machine learning and AI, and anything that can be measured that is multi-dimensional or multifactorial, it can be exploited to help provide better precision. This is a paper that was that Eliane Kobayashi and myself, with collaborating with this Spanish group, who's an expertise in machine learning and these types of models. These are Bayesian, these are multidimensional Bayesian classifier methods. Just a way of really dealing with a lot of unknown data. So even when you have, we threw into the learning mode of this all the variables we could get that had any possibility of being something you would want to weight that potentially had effect on outcomes. But there's a lot of unknown data no matter what. There's also a lot of unknown data between outcomes from 1 to 2 to 5 or 10 years. So this can take advantage of on two levels. It can say, well, you may not have those measures for every single patient, either the variables of interest or the outcomes of interest, but it can deal with both of those sets of unknowns to some degree with imputation. Imputation is a way of statistically sort of filling in unknowns and values in tables. And this does it with these models that sample through in a Markov statistical analysis, where you run scenarios thousands of times with varying the estimates of these unknowns, and using what little weights you have from learned samples and then applying them to newer samples. So this was actually pretty cool, but it's sort of a proof of principle, because I mean, the long and short of it is it did have better predictive power than, say, the nomograms or the scoring scale that I showed you, modestly better. And they're all relatively modest. But it really is ripe for being exploited with more data, basically. We threw in a few hundred patients, but when you start throwing in thousands of patients, and then it's really going to shine, I think. So I want to talk about, like, what else can we do, though, that remaining variance, because there's a ton of variance that remains. Like I just mentioned, patients that are well matched, and that's what and still have completely different outcomes. And I just chose these two patients that are right off the press. Like, one of them just had surgery a couple of weeks ago, so I don't have outcomes, but the other one is in the hospital right now. That's patient 2, and patient number 1 was just a couple of weeks ago. They're both young adult males. They are they have normal MRI, classic sort of beautiful ictal patterns, temporal lobe epilepsy, semiology. They have similar auras. They have similar imaging, not exact. I mean, it's another issue. It's hard to match people, and I certainly could have done a better job. I just picked these 2 recent patients because they looked the same. I thought, man, these 2 guys are the same. kind of figuratively, like they're the same age, kind of long hair, both. And they both have a ton of electrodes in their head, or they did, one of them did, and now the other one does. You know what? I guarantee you one of the two is not going to be seizure free, and one of them probably will be. And there's a lot of variance. I mean, there's even variance in here. I couldn't, one of them has ipsilateral only spikes. The neuropsychology is a little different. One of them's mostly intact. The other one has more of a focal verbal language, verbal memory, and kind of fits with his left-sided surgery, his left-sided dominant temporal lobe. The other one is mostly intact. He does have relatively mild decreases in visual memory, but how reliable is that? But at least it's, they're not that different, but they're not the same. And PET's a little bit different. Seizure frequency is definitely different, but they both have convulsions. They're not that infrequent either. I was surprised. I thought, oh, they probably have rare convulsions, but no, they have at least a few a year at least. So they're both, they're both at risk for SUDEP, but they're really pretty similar. This is their intracranial EEG that makes it even more confounding to me, because we put all these electrodes in because they don't have like a perfect medial temporal aura per se, although deja vu, but anxiety, certainly very common, but they're normal MRI. We still implant these patients, particularly when they're language dominant. This other patient was number 2, is left-handed and thought to be possibly language dominant on the right. And we said, well, we're going to be implanting him anyway. We will confirm that. But they both have just purely hippocampal onset seizures, and not just by a lot. I think we have electrodes all around in orbital frontal cortex, lateral temporal region, insula. But these seizures, they start in the hippocampus and amygdala, and then they spread to the temporal pole, and then they spread to the anterior lateral temporal lobe, long before they spread and secondarily generalized. This one's a little bit different, although it's just because of the voltages and the hippocampus again, same thing, really a little bit quicker spread, a little bit quicker to the neocortical basal temporal regions, but long before it generalizes. It's just with unequivocal that it's mesial temporal in onset. And they're both going to get similar resections. They're going to get anterior medial temporal resections that are going to remove all of these electrodes that are involved in this seizure onset in this page. And there's only 50% chance they'll be seizure free. So I sort of said, well, maybe biomarkers. There's a lot of literature that's coming. There's another field that's blowing up because of because of computational science and quantitative measures. And a lot of work that's even been done at Montreal and imaging with Dr. Gottman's lab and all the folks that work there, fMRI and EEG, and Bernasconi lab and quantitative MRI. But there's just so much that can be done, and it is going to be fun to see how this all pans out. But I just threw up a montage of tried to organize all of the biomarker measures that we can do, whether they're imaging or neurophysiological, and just threw them up on the wall in this chart, because there's many papers and instances for any one of these features or measures to be measured and associated with outcome. Frequently with respect to whether the measure that is found to be weighted strongly with outcome is included in the resection or not. But it's still very complicated because when you try to define what was included in the resection, it certainly can be done with postoperative imaging, but it's not perfect. And certainly the predictions are not at all perfect. But a few take-homes from this, and I think we all probably know this because we all have some working knowledge of some of this literature, that one of the big take-homes is there is, I think, emerging kind of foundation of evidence that says you can detect with many of these methods, abnormalities outside of the seizure onset zone. And they can be structural or functional, metabolic or connective wise. And the question is, to what degree does that extra seizure onset zone abnormality, to what extent do you have to take that into account or should take into account this distribution of abnormalities? If it's a distribution of remote abnormalities, or differences in specificity, differences in patterns, not just extent, but patterns of abnormalities. That would be, probably more akin to connectivity or cortical evoked potential distribution. But it is an area of research that is really ripe for exploiting, sort of like in the same way that machine learning will be for looking at variables, clinical variables in weighting. But I don't know yet, I don't think any one of us uses these methods, even though there's been lots published, I don't think any of us uses, say, cortical thickness measurements to make a decision about a patient being able to go to surgery or not. And the same for connectivity measures. And we may use some of the ECOG patterns, like some of the patterns that have been identified that are very specific for focal cortical dysplasias. Maybe the HFO distribution we may have brought into clinical use, but no sort of large clinical evidence to tell us how to use these tools. But I just had to cover it because I think this is the only way we're going to get some answers to these patients that are well matched from a clinical standpoint, and those that become seizure-free versus those that don't become seizure-free. So I'll just conclude quickly. I hope I haven't been way over time. I think it's pretty clear that the seizure onset zone is not necessarily the epileptogenic zone, unfortunately, because that is what we basically focus on right now. Larger resections are better than smaller ones, and even probably with many lesionectomies. And if there's a lesion anywhere near the medial temporal structures, you may well have to heed taking those. Reoperation should definitely be considered. Most of the studies, they're all limited studies, no matter what, even if they're not limited by size, they're retrospective and observational. But, about half the patients that have reoperations achieve seizure freedom. And that goes to this, like, well, why didn't we do a bigger resection in the first place question that's still unanswered. Maybe with these biomarkers, we could do a better job of defining the tissue beyond the seizure onset zone that has to go. Even though these models that we have for predicting success and failure are not perfect by any means, they are still helpful in creating patient expectations, which is something we do need to do. But I always end that, which I have alluded to earlier, conversely, there's a reverse risk for over-selecting cases, and we should at least be cautious of over-selection, because precluding patients that can be seizure-free is the result of over-selection. And now what we know about SUDEP, that's not trivial, as well as quality of life. There's one thing you can rely on for quality of life after surgery, and it is being seizure-free. And if you're precluding people from being seizure-free, you're precluding diminished mortality risk and quality of life. And the converse, the result of not having surgery, I guess, you could always argue, is not a whole lot different than having surgery that fails in many patients. Of course, that's not the case when there's deficits, but we usually try to avoid those. And I'll stop there.